Okay, you're good.
All right. Thank you. Good afternoon, everyone. Had to check the clock to make sure it was that. This is the Insurance and Pharmaceutical Subcommittee of the Health and Government Operations Committee. We have a packed agenda today, and we have 50 minutes to complete it. It is my understanding that most, if not all, of these bills are worked either very, very close or are completely worked out. So I am not anticipating a lot of discussion on the bills today. Really, just a clarification around what they do, and if there are amendments, where we are on those amendments. So, with that, we are going to start with House Bill 1310, Prescription Drug Repository Program, out-of-state pharmacies. That's Delegate Bandari's bill. Lisa, tell us what the bill does and if there are any amendments.
The bill authorizes a pharmacy licensed in another state to participate in the Prescription Drug Repository Program. The bill defines licensed pharmacy as a pharmacy licensed by the Maryland Board of Pharmacy or a pharmacy licensed in another state, and redefines repository to mean a licensed pharmacy that does not have final disciplinary order issued against it by the board or for an out-of-state licensed pharmacy, the applicable regulatory authority, has voluntarily agreed to participate in the program and has been approved by the board to accept donated prescription drugs or medical supplies from a designated drop-off site. To dispense the donated prescription drugs or medical supplies to needy individuals or dispose of the prescription drugs or medical supplies not accepted for dispensing to needy individuals. And there are no amendments on this bill.
Okay, there are no amendments. Delegate Bandari, would you like to speak to the bill? Okay. Is there
Move the bill.
I've got a motion on the bill. Do I have an amendment? I mean, do I have a second? Delegate Johnson, are you seconding or you have a question?
I have a question, Madam Chair.
Okay, I heard a second, but go ahead, Delegate Johnson, with your question.
So is there anything that guarantees they're going to be doing advertising and rolling out a campaign to make sure that Maryland residents know about this program and that we are recipients of some of these drugs?
I'm going to ask if Andrew York is on. Is Andrew York on? If he's not on, I'm going to go to George Wang from Cerium. And can you answer the delegate's question?
Yeah, I mean, the intention here is absolutely to be to help Marylanders as much as possible. I think organizations like us, including us, have been talking with the Prescription Drug Affordability Board and the governor's office about making sure that it's widely available for patients and widely marketed. I'm not quite sure that there's anything specifically in the bill for that, but we'd be happy to discuss that. But we're very excited about the opportunity.
I would like to hear more about the plan that lets Marylanders know about the program and what's available. Thank you, Madam Chair.
Delegate Johnson, do you need that in order to be comfortable with the bill, or are you okay moving the bill?
No, I'm okay with the bill, Madam Chair.
Okay.
We can just do that offline.
Okay, great. Delegate Shalega.
Thank you. I'll channel Sue Krebs. What problem are we trying to solve? I looked up the Prescription Drug Repository Program, and it's for donated prescription drugs or medical supplies. Do we have out-of-state people trying to donate and they can't? Just a little explanation would be helpful.
George Wang?
Yeah, I can answer that. So, from my recollection, the current statute in Maryland doesn't allow, is not as an expansive program as what other states are now doing across the country. And so one of the things it allows is that it allows nonprofits that are operating these programs in other states to also participate, providing medicine to Marylanders.
Right.
And so that is a key component in which other states have leveraged a similar concept of allowing cross-state platforms to operate, which have then allowed their programs to grow much more robustly. A lot of these programs are just run by small nonprofits, but this allows bigger nonprofits to participate and really affect a lot of change for folks that can't afford their meds.
Okay, and then finally, the fiscal note, is there one, or what is it?
I believe Andrew York is on, and he's going to address the fiscal note for us.
Yes, and I apologize for not being on earlier. I was sitting on a different link. So thank you for your patience. So our understanding is that a letter has been submitted by the Board of Pharmacy that we were able to find efficiencies, and I think the new fiscal note is $58,000 for a single FTE to help monitor and regulate the new repositories.
And that's within our target.
And okay, so we need to hire a person to do this, is what you're saying?
We defer to the Board of Pharmacy. It's all the out-of-state repositories need to be registered as a non-resident pharmacy. So they're already regulating them. So they should have folks on the ground as well, but we defer to the Board of Pharmacy in terms of if they need additional staff to manage the repositories. Our understanding is the same folks can do the same work since the pharmacy is already being regulated by the board, but they may have needs for additional staff. So
that's the fiscal note is 60 grand roughly.
Roughly.
Approximately, yes.
Okay, thank you.
Okay. All right, I have a motion and a second on the bill as presented. Those in favor of the bill as presented, please say aye and
Aye.
raise your hand.
Aye.
Is there opposition to the bill? Raise your virtual hand. Seeing none, the bill passes unanimously. Thank you all very much. Next, we're going to House Bill 1315, Health Insurance Coverage for Child Wellness Services, Immunizations, Delegate Gazzoni. Lisa? Lisa?
Yes, sorry.
Okay,
So as amended, this bill requires specified insurance policies and nonprofit health service plans to include in their minimum package of child wellness services required under current law all visits for and costs of childhood and adolescent immunizations recommended by the Center for Disease Control and Prevention's Advisory Committee on Immunization Practices on December 31st, 2024, or at a later date to account for new recommendations. The amendments also specify that the pharmacist's authority to administer vaccinations is based on the recommendations of the CDC's ACIP on December 31st, and they provided the coverage. There was a reference to the Academy of Pediatrics, and that has been stricken for consistency purposes, so it just references the CDC's ACIP too.
Okay. So we tried to address the concerns that were raised yesterday. Do I have a motion on the amendments? Let me get a motion first, and then I'll go to
So
Christine.
moved. Second. So moved.
Okay, I've got a motion and a second. Christine, you had a question or comment?
Good morning. Lisa, could you explain the consistency piece about why the American Academy of Pediatricians is being removed?
It's being removed, in part anyway, to be consistent with another bill that we already passed that was the preventive
974.
service the preventive services bill, and that only references the CDC, and it applies to adults and children. But
we would urge that it be left in there, but understand.
Any further discussion on the amendments? Seeing none, those in favor of the amendments, please say aye. Raise your hands.
Aye.
Any
Aye.
any opposition to the amendments?
Bill as
Seeing
amended.
none, that's unanimous. Can I get a motion on the bill as amended?
Move the
Bill
bill as
as
amended.
amended. Second.
Okay, a
Second.
motion and a second on the bill. Any discussion on the bill as amended? Seeing none, those in favor of the bill as amended, please raise your hands and say aye.
Aye.
Those who are opposed, Aaliyah, we're in the,
Shaleg is a no.
okay, yeah. Sorry, I didn't ask for the opposition yet because I'm seeing Aaliyah, we're in the voting process. Okay. So Delegate Shalega is a no.
That's why I weighed in. I didn't think Aaliyah got to vote, so. I'm a no.
Okay. Okay, the bill passes. Thank you very much. And thanks for looking out for Aaliyah, Delegate Shalega. We're going to the the person celebrating a very important birthday today, House Bill 1351, although I didn't learn what that important birthday was. Health insurance provider panels credentialing for behavioral health care. Lisa, tell us what the bill does.
The bill requires carriers to complete applications by certain behavioral health providers to participate on their provider panel within 30 days after receipt of a completed application from specified providers. What the amendments do is limit the types of practitioners that the bill applies to and require completion of credentialing within 60 days instead of 30 days.
Thank you, Lisa. Welcome, Delegate Grist, and happy birthday.
Thank you very much. I appreciate it.
Would you like to speak to your bill?
No, I would. I just want to actually just thank everybody for their hard work on this. And this is one of the wonderful things about HGO is you guys are very collaborative. And you give, everyone the opportunity to, to come to some sort of consensus. In this case, we did. So I'm going to thank the committee for that. And then also, thank all the stakeholders. It was a good process.
Thank you. Thank you for your participation in it. Can I have a motion on the amendments, please?
Move the amendments.
Second. Motion and second on the amendments. Any further discussion on the amendments? Seeing none, those in favor of the amendments, please say aye. Raise your hands.
Aye. Aye.
Aye. And anybody opposed to the amendments? Seeing no hands, it's unanimous. Can I get a motion on the bill
Move the
as
bill
amended?
Second.
Got a motion on the bill as amended. Any further discussion on the bill as amended? Seeing none, those in favor of the bill as amended, please say aye. Raise your hands.
Aye.
Will there be opposition to the bill as amended? Seeing none, the bill passes unanimously. Thank you all. Thank you, Delegate Grist, and enjoy the rest of your day as much as you can. We will go to House Bill 1355, Health Insurance Required Coverage Hearing Aids. Delegate Riley. Lisa, tell us about 1355.
This bill alters the current health insurance mandate regarding coverage of hearing aids for adults to require coverage if the hearing aids are ordered, fitted, and dispensed by a licensed hearing aid dispenser. And there are no amendments.
No amendments.
the bill.
Well, let me see where if Delegate Riley is here first. I
Yes,
thought she
Madam
was.
Chair,
Yes,
here I am.
yes. Delegate,
Yes.
would you like to speak to your bill?
Well, again, it's just, clearing up a little bit of what we failed to mention last year when we went through the exchange and went through the carriers to make sure that this was something that we could do for that small group of insurers that are on the exchange could provide hearing aids to adults, which we passed. And then we found out that the audiologist and by FDA and even here in Maryland, there's several by fitting hearing aids. Audiologists can do that and also hearing aid dispensers. So we wanted to add them to the bill. And I believe there is no opposition to the bill. Verified that a little bit earlier today. We did have one in our bill file. And that was because they thought they were looking at the original bill in the Senate where we added children, and that was not the bill. So,
Okay. Thank you, Delegate. Thank you for your work on this. Delegate Kaiser.
Thank you, Madam Chair. I was just wondering, and this sounds like a great idea. I was just curious, what is the cost on this? Or is it just a small change?
it's a small change.
It's a small
Yes.
change.
And
No
the cost
cost.
back last year was very minimum. That's why the exchange, the Maryland Healthcare Exchange and the carriers agreed to allow for this.
Great. I think I heard a motion on the bill. Did somebody?
Yeah.
Delegate Bandari,
Second.
do you have a question?
Second.
Okay, got a second. Got a motion, a second on the bill. Those in favor of any further discussion? Those in favor of the bill, please say aye. Raise your hands.
Aye.
Any opposition to this bill? Seeing none, it is unanimous. Okay, is Delegate Fair here?
Thank you.
Is Delegate Fair himself here? I see his staff is here.
No, Delegate Fair is in an education subcommittee meeting right now.
Okay. All right, Camilla, it's up to you then. We're going to House Bill 1059, Health, Maryland Helping Everyone Afford Life-Saving Treatments and Healthcare, otherwise known as HELP, Fund and income tax checkoff. Lisa.
The bill establishes a Maryland Helping Everyone Afford Life-Saving Treatments and Healthcare Fund. The purpose of the fund is to assist Medicaid enrollees and individuals with health insurance with healthcare costs associated with healthcare services and benefits provided under state law that are subject to federal restrictions, including funding restrictions. The executive director of the Maryland Health Benefit Exchange must report annually on administration of the fund, and the exchange must adopt regulations to carry out the fund. The comptroller must include a checkoff for the health fund on the individual's income tax return form. After the comptroller deducts administrative expenses, contributions are credited to the fund. There are no amendments.
Okay, thank you. Camilla, would you like to speak to the bill?
I think, Lisa did a wonderful job explaining what the bill does. It allows Marylanders to make voluntary donations either directly or through a tax form checkoff to support Marylanders' access to healthcare, things like losses to Medicaid, which pays for approximately 41.7% of births in Maryland. Other states have similar programs, either for research or like this, directly to the provision of healthcare services. So just thank you for your consideration.
Thank you. Lisa, did you say there are no amendments on this bill?
Correct.
Right, okay. So questions, discussion. I see Amelia Marcus from the Healthcare Exchange. Amelia?
Thank you, Madam Chair. The exchange had missed the deadline to submit testimony for this bill. This is Amelia with the exchange for the record. I think we were interested to have more discussions on how this bill would be implemented, but we sent a letter to the sponsor and said that we're, more than happy to work with them and happy to work on this bill with the committee. The one technical amendment that we did want to note is the bill currently gives the executive director of the exchange the authority to administer the fund, and that responsibility is usually delegated to our board of trustees. So we would recommend that that's amended into the bill.
Let me ask you, Amelia, if that's amended into the bill, can the exchange support the bill going forward with discussion?
I do think our executive director is out, and I think that we would have to have a little bit more of a discussion, but we are happy to have it and are happy to work with the sponsor and the committee.
Okay, Delegate Shalega.
Thank you. So that was kind of one of my questions that Amelia raised.
Mhm.
And then secondly, I'm reading on page 2 of the bill, the program enrollees and individuals with health insurance for healthcare costs associated with healthcare services and benefits provided under state law that are subject to federal restrictions. So, one of the federal restrictions I have heard is coming is that able-bodied people without children, able-bodied adults without children who currently qualify for Medicaid may not qualify under federal restrictions. So would this pay for them?
I believe that's the intention, that for
Okay, so
folks who
this
cannot be insured. Right.
Okay, so if this is focused on able-bodied adults without children to collect Medicaid without a work requirement, and there is some funds collected, but not a lot, who's going to decide who gets it and who doesn't?
If we make the adjustment to the Exchange Board of Trustees, that's how it would be administered.
So what's going to be the priority assessment? Because there could potentially be the other thing would be gender affirming care may not be permitted. And so then are they going to also be on the list for people who could get this?
I would imagine that they would. It's not specific to any kind of healthcare. It is healthcare in general. So whatever healthcare is medically necessary, a person would qualify for.
Right, but I don't see any priority list for funding. I think that's what Amelia's saying. How is the program going to be administered?
I think that's what I'm hearing from Amelia as well. So I think that you're raising some implementation questions, and Amelia is as well, so I think we probably should have more discussion about this bill. Is there any objection from the subcommittee on that?
No,
Seeing none, we'll hold this bill until we have a chance to sit down, and we haven't really had a chance to work on it. All right, we are going to move to, is Delegate Tolles here?
She
Delegate-
may have had to go to subcommittee to vote, Madam Chair.
I
Okay.
see her listed. I don't, but she's not on camera, but she
Okay.
is in the list.
Okay, good.
I know
And,
she had told me she was voting at 1:30, but
Okay. That's, all right, well, we are gonna go to House, if we have Caitlin here, and I think if Delegate Tolles is on the list.
I'm here. I'm sorry. I
You're
stepped
right
out of the
here.
office.
Right
I
here.
stepped out of the office.
Wonderful.
Sorry.
Okay, I've got House Bill 1251,
Yeah.
healthcare facilities and medical professional liability insurers, obstetric services policies, doula and birth policy, Transparency Act. Delegate Tolles, Lisa, would you tell us about the bill first?
Yes, thank you so much. The bill is essentially, as I said in committee, so thank you, Madam Chair. It would allow for birthing parents to have someone other, not other, but in addition to a spouse or some partner in the room with them to have a doula. Oftentimes, doula has been with the, with the parent throughout their pregnancy, and they feel, doulas are a little bit different in terms of comforting, and offer other, medical assistance, not medical assistance, but assistance, with the pregnant, with the woman. And so we want to be able to ensure that that doula can go with that parent in the hospital for the delivery. And so that's what the bill does. Currently, hospitals can only allow just the spouse or the partner in the room with the birthing parent, but we want to be able to expand that to allow for a doula to be in the room. We do have several amendments, Madam Chair. And if there are no questions for me, or I can have the amendments be talked about with Caitlin McDonough. We've been working with the Hospital Association and other advocacy groups to get this bill, to a good place. And I would like for her to go over the amendments if it's time to do that, or if anyone has any questions, whatever direction you would like, Madam Chair.
Oh, thank you very much, Delegate. Thank you for your work on this bill and for being here. I'm actually going to ask Lisa Simpson to describe the amendments.
Sure.
And then I'll get a motion on the amendments, and we'll have the discussion.
Sounds great. I'm gonna get up and close my door, so I didn't leave, okay?
Okay, thanks. Lisa?
So the amendments limit the provisions of the bill to hospitals. As originally introduced, it would have applied to healthcare facilities. But, and the bill would also, the amendments require the hospital to provide evidence to MDH of having a doula policy, an informed consent policy, and a transfer acceptance policy. And the amendments also specify that MDH is only required to provide policies to the public on request.
Okay. Can I get a motion on those amendments, please?
move the amendments. Second.
Okay, and a motion and a second. So let's have any discussion on the amendments. Oh, thank you, Natasha. I was hoping you would. Natasha Mayhew, tell us from MHA's perspective, how's this bill?
Yes, thank you, Madam Chair. We have been working really closely with the sponsor, Delegate Tolles, with Caitlin, to get this language correct. We've been going back and forth on a couple of different revisions. I think we're very close. There was one thing that was flagged. Oh, actually, I'll say a couple of my hospitals still had the latest rounds with their counsel for review on the language. One of the things that was flagged is that in changing from healthcare facility to hospital, it still left it broad, the broader definition of a hospital. And so we did just want to, and I shared this with Caitlin, have that clarifying language that it's the hospitals with obstetric care, which was originally in as it described the healthcare facility and had the other hospital definition. So a lot of this is, as we've been going back and forth through the drafting, just making sure that language is clear.
Delegate Tolles, is that a friendly amendment to you?
Yep.
You're on mute.
Thank you, Madam Chair. Yes, that is a friendly amendment.
Okay.
Yeah, I don't want to hold it up, but I do have just a point of clarification. Do we have let's just, I guess, take for example, someone that's pregnant would have to go to the hospital and they don't have obstetric care. Would they take, and I'm sorry if that's a crazy question, but sometimes you have emergencies and you try to find the closest hospital before they could, transfer maybe them to some hospital with option. I've had the same issue in committee. You always setting this word up. Better be with this word, but my point is, can they be transferred to a facility?
Yes, thank you, Delegate. And I'll actually say that when it comes to emergencies, there are protocols that EMS must follow. There's perinatal standards in the laws, and hospitals are categorized from like level 1s to level 4s. And so when there are emergencies, EMS under MINS regulations, they direct more complicated cases to the hospitals that are levels 3 and above, because those hospital labor delivery units have the expertise and the equipment, like neonatal intensive care units, to deal with those sorts of things. There are also hospitals that are just level 1s and 2s when it comes to their birthing centers, and they only are able to do, less complicated, simple, unproblematic births. But that is something that's currently in law and other laws as it relates to how those transfers occur when EMS is brought in to bring in someone that is giving birth. And then I guess kind of to your other point, there are also other transfer policies when it's just someone's going to an emergency department for instance, emergency care. And we do operate under EMTALA laws where in those cases, a patient gets stabilized to the extent they can be stabilized. And once they're stabilized for transfer, then they can be transferred to another facility.
Okay. Is that good, Delegate Tolles?
Yes, just had a quick follow-up, Madam Chair. And so with your facilities, would that doula be able to be with them while they transfer to? Would you think that would be a problem?
So that was something that we've been discussing also in relation to the other bill with the midwives, because in these cases, and Caitlin, correct me if I'm wrong, is that there are other provisions where midwives are currently required to accompany the patient to the hospital. A little confusing because we're dealing with two different bills here, but part of trying to work out these transfer plans and the requirements that currently stands for the LDEMs, plus the requirements here where we're trying to bridge those communication gaps, does have to deal with whether or not, a hospital requires that. So some may not. And that's one of the things that is intended to be addressed by these transfer plans. And Caitlin, sorry.
Okay, I'm going to go to Delegate Szeliga.
Thank you. So I'm a little confused because the title of the bill says professional liability insurance, but has that part been stricken out of the bill?
No.
Okay. So are we then saying that the hospital, and Natasha can answer this, is now providing professional liability insurance for doulas when they come to the hospital with the patient?
The amendment is, or the provision is on request and ensure that issues or delivers medical professional liability insurance policies in the state shall provide the Department of Health with information regarding the policy related to coverage of obstetric services. So there's nothing requiring coverage. It's just saying if they do, they can.
Yeah.
I'm reading the 3/14/10:55 a.m. reprint. Is that the latest one?
So the provision I'm reading is on page 3 of 3.
Okay,
Okay,
that's
lines
all been stricken out. Oh, okay, hold on.
lines 20.
Okay, so it's not a mandate that the hospital's now gonna expand liability insurance.
Correct.
No.
Okay,
Right.
then my next question is this. Doesn't the hospital already have the transfer acceptance policy? Didn't, and maybe Caitlin or Natasha can answer that. I mean, we did quite a bit of work on that.
Caitlin, I'm going to go to you for this.
Sure. So, and a couple different issues here. So one with doulas, and doulas are different from midwives.
Mhm.
This is just letting them, we were having situations where only one person could be in the room. So people were having to choose between a doula and their partner, essentially. So this kind of addresses that. Another provision of the bill is, and there's two bills kind of simultaneously moving, and I'm hoping in an hour we'll be moving the other one, that midwives, direct entry midwives, have a series of statutory provisions that are placed on them in current law when they transfer to a hospital, that are being, that are already existing in current law and being somewhat tweaked in the other bill. What this bill does is on the other side, so the hospital receiving practitioner who's then receiving that transfer would develop a policy. So we kind of know, so from the midwife perspective, they know where to send the records. Is it to the delivery nurse? Is it to the ER, to the receiving practitioner? We leave flexibility for the hospital to develop what works for them. But having a policy on both sides, so midwives know what to do and hospitals know what to expect, it's like they do kind of work together. And there is a provision in this bill that would kind of link the two provisions of law together. But some of it is, what's required of the midwife, and some of it's the policy that would be developed by the hospital to receive that birth.
Okay, and then my last question, and thank you, Madam Chair, for indulging me. I would say, why can't the hospitals allow, why are they so restrictive? I mean, my kids are in their 30s, and I could have had a party in the delivery room. And, they were fine with that. But, if I wanted to have my mom-in-law join me at the birth, and they're my acting doula, not a certified doula, but we know what a doula is. Couldn't my spouse, and couldn't I also have my mom in there and potentially my mom-in-law? Like, why are we being so restrictive on who can come in the birthing room? I get the infectious disease control, blah, 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 but most births are, you're pushing people to have more births outside of a hospital when you're this restrictive.
Yeah, and
Natasha?
part of that, a lot of times, particularly, for instance, as you raised, when there was COVID, there was very tight restrictions. Other things may happen where complications arise, or there's disruptiveness, where the hospitals would want to limit how many people are in the room. Part of this here is to balance that a little bit, the understanding that someone may want a doula in addition to their spouse or otherwise, but also respecting the fact, and there was language out of there in the amendments, that there are times and situations that hospitals need to limit the amount of people that are in the delivery room. But this strikes that balance to allow doulas, but then also when it's needed, really, that the hospitals can still maintain the limitations for the
Right.
safety of all involved.
I think what you're telling me is they're only letting in a spouse. And I know when my daughter-in-law delivered, like they only let my son in. So I don't understand, if we're going to allow doulas in, why can't we allow another person in as well? Can we say may?
Delegate, I appreciate your question, but if we could potentially move this bill, because the doula has been the issue of this bill, and if we want to talk about the future in terms of who can be more expansive over who can be in the room, I think, can we have that discussion before next session?
Yeah, I mean, this is the opportunity to just add doula or, family member. I mean, why couldn't we just add or family member and open it up to, another, a spouse and or a significant other and a family member?
Natasha?
They're currently allowed. So what
Okay.
the only issue we were trying to address here was concerns that there would be times that the doula in addition to someone else wasn't allowed. And so that's clarifying that a doula can be in the room in addition to whoever else the person wants, but also acknowledges that there would be times and situations where you can't have like 8 people in a delivery room, so the hospitals would need to restrict in those cases. But again, the intent here is to allow the doula in addition.
Yeah,
In
I guess
addition to family
I
members.
wasn't communicating it well. If we're gonna
Right.
say doula, why can't we say doula or acting doula? So, you know, if we're gonna let it, again, you know, I get what you're saying, Bonnie, but to me,
Yeah.
it just seems, it seems like we have an opportunity here to allow to make the hospitals be a little more inclusive in a labor and delivery situation.
And if I may, I will add that as we were going back and forth through the language, we did change the doula language to broaden it for the types of doulas that there are. Like previous versions of the bill had it linked to a statutory reference that was very limiting, didn't actually include the scope of doulas. So we have been working to ensure that it's not, and I was saying spouse, but really it's a guest of the person. So it's the
Okay.
doula with that broadened definition and whatever guests.
So it could be, I think we could accomplish that by, if people want that, they could just indicate that their mother was the doula. All right, thank you. I can accept that.
Thank you, Delegate. I appreciate your questions. Anna, do you have a question or a concern? Anna Rodney?
Hi. Thank you so much, Senator. I'm a doula, and I actually was able to testify on this bill, and so I was just attempting to bring some clarification to the need for the language of doula as opposed to just a family member or a friend. But it seems like you guys have gotten it taken care of.
We are there. Thank you. Thank you for being here, Anna. I've got a motion and a second on the amendments. Can I, those in favor of the amendments, please say aye, raise your hands. Anybody opposed to the amendments? You don't get to oppose, Caitlin.
No, I was just going to just say for the record, if adding that the hospitals are ones that do obstetric care, that Natasha, that was the original intent. It did get lost a little bit in the redraft. So if you can vote, I don't know if you can vote that in concept. We're fine.
Yes.
That's fine. So would it be hospitals has the meaning stated in 1903 that provides obstetric care?
I think so. Yes. That's what I'm going to say.
Okay, I can do that.
Yeah.
Yep.
Okay. Do you have any opposition to the amendments with that addition?
Move that.
Okay. Seeing none. Okay. The bill as amended. Can I have a motion? Did I hear that?
The bill is
Motion to
amended.
bill. Yep, second.
Got it. Any discussion, any further discussion on the bill as amended? Somebody needs to, okay, Delegate Taveras, did you have?
I just want to clarify. So that's page 2, line 11.
The definition of hospital?
Yes. Is that where we're making that change?
Yes, it will be a hospital that provides obstetric care.
Yes.
Okay, I've got a motion and a second on the bill as amended. Those in favor of the bill as amended, please say aye, raise your hands.
Aye.
Anybody opposed to this amendment? To this bill as amended?
Bill as amended.
Seeing no hands, it passes unanimously. Thank you all very much. We're going to House Bill 1087, Health Insurance Step Therapy.
Thank you, Madam Chair. Thank you, colleagues. Thank you.
You're very welcome, Delegate Tolles. I'm sorry we're kind of rushing. We got about 12
understand.
minutes here.
Okay, thank you.
The step therapy or fail first protocols, drugs to treat associated conditions of advanced metastatic cancer. We had a discussion about this bill yesterday. We had a question about one of the amendments being offered by the carriers related to biosimilars and genetics. In doing some research and some thinking last night, I was afraid that sentence took the bill back to to current practice and was going to minimize the impact of the bill. So I'm asking if the subcommittee would consider moving the amendments that are in the reprint of, I think it's today. Is that right, Lisa? Did you send out the reprint today? That does not.
I sent it out again today, but it's the
Okay.
same.
It's the same without that amendment prohibiting the process when there is with respect to biosimilars and generics. Can I
Move
have
the
a
bill-
motion on
move
the amendments
move
that
the
were in the
amendments
reprint?
As the chair suggested.
And is there a second?
Second.
Okay, I have a motion, a second. Is there any discussion on the amendments? Seeing none, those in favor of the amendments as presented, please raise your hand, say aye.
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 Okay, any opposition to the amendments? Seeing none, those are unanimous. A motion on the bill is amended.
Move the bill as amended.
Got a motion on the bill
Second.
and a second. Any discussion on the bill as amended? Okay, seeing none, those in favor of the bill as amended, please raise your hand or say aye. And any opposition? Okay, great. Thank you all very much. We're going to House Bill 830, Health Insurance, Genetic Testing, and Cancer Imaging, Required Coverage and Prohibited Cost Sharing. Delegate Jones. As I explained yesterday, I think, and I think Mr. Celentano did as well, these even when with our best intentions to provide the very best health care, we also have to look at the total impact of the mandates that we are creating. So with that in mind, we offered yesterday the ability, not the ability, but mandating the testing. And I have to check, Matt, can you tell us, is that mandating without prior authorization or in the amendments?
It is mandating coverage of the testing, which Maryland does not do. And the reprint retains the ability for carriers to have cost sharing.
Yes, but I'm asking about, is there prior authorization for the testing?
I do not believe so. If it's a mandated coverage.
Okay, so we're saying that the carriers would cover the testing, the major part of the testing, with the patient paying only the copay or co-insurance for those tests. I'm going to ask for a motion on those amendments.
So move.
I got a motion and
Second.
a second. Okay, now we've had extensive discussion on this and we have 7 minutes. So I'm going to ask you to be quick in your comments. Patrick Hogan.
Thank you, Madam Chair. In respect to the time, I will just defer to our client, Susan G. Coleman. Angela Katz has raised her hand as well. Thank you.
Okay, thank you. Angelica?
Thank you, Madam Chair. So I just wanted to reiterate, this bill will essentially help save, the long-term savings will outweigh the minimal upfront cost of genetic testing. Like, we know that individuals who are proactive about their health, who participate in early prevention and treatment will down the line have lower healthcare cost overall. It's good for the healthcare system. It's good for the carriers. It leads to just lower visits to emergency rooms. And I will say as well that what is currently being done wouldn't change if you were to keep the bill as is with the amendments. So we would have to be opposed to it if there is cost sharing in the language, because that is the barrier that we're seeing. We want to make healthcare as accessible as possible. And so we're we want to keep that language in the bill.
Understood. Delegate Shalega.
I'm thinking of Nick Kipke's question where he asked, did we study this first to see what the cost is? Don't we usually do that?
We did, and the study was, there are varying positions in the study. And the study said, gave a range of cost, and it went from 2 cents per member per month to 53 cents per member per month, with an average of 17 cents per member per month. This subcommittee generally doesn't look at anything over 5 cents per member per month. Again, sounds like a tiny amount, but when you add it to all the other 50 mandates we have, it does add up, and it does affect premiums. The bill is amended, mandates the testing. So the testing, right now that mandate doesn't exist, and the carrier can decide that the testing is not medically necessary under the prior authorization rules. So what we're doing is making sure that the people can get the test with these mandates. And also there was a question about in the test or in the report about the efficacy of the tests. They're relatively new. They have, we don't know what they are, how reliable they are in terms of finding the markers. So I think doing it this way with the mandate, we'll learn about the testing, what the impact is, and we can always come back going forward around the cost sharing.
So it does have cost sharing.
It has cost sharing for the test, the secondary test, right? This
Okay,
is
and
not the initial test. This is the secondary test.
Okay, and I'd like to hear from Matt. Thank you.
Matt?
Madam Chair, I just want to clear it up a little bit. Yes, Delegate Shalega, there is a cost that comes along with this bill, and it ranges from, like Delegate Collison said, to the very low end, which is negligible, to the high end, which could be 53 cents per member month, which is a lot. And contrary to what I've heard from the advocates, this doesn't create problems. I think the mandate of the test is the most significant cost impact. These tests are really, really expensive, and which is why the carriers are opposed to it. But if the wisdom of this committee wants to move forward with this, a way to mitigate some of that cost impact is to allow the carriers to retain cost sharing. In the past couple of years, well, for many years, we've had lots of mandate bills, but in the past couple of years, all the mandate bills have started to be introduced, mandate and no cost sharing. That's a double whammy to the impact of premium. So if we can retain some of the cost sharing, and we're talking about copays of maybe $15, $20, that can help offset some of the spending. The tests are really, really expensive. And what we're mandating here is the expensive tests. But if you let the carriers retain some of the cost sharing, we can mitigate some of the impact. And that's what we're asking for here. We still oppose the entire bill. I just want to be very clear about that.
Okay, what's really, really expensive?
I think Delegate Collison referred to it, but anything over 5 cents per member per month has impact if the carriers start to get uncomfortable. This bill in the MHCC study was showed to be 53 cents per member per month at the high end. That's a pretty high PMPM from an MHCC study. It's not, and like Delegate Collison referred to, it's not just one mandate here and there. It's the collective amount of mandates that are really impacting premium. We have 50 mandated benefits in Maryland, which is outsized compared to the rest of the country. And it has impact on premium. And we want to make sure that we keep having an affordable product, because affordability is accessibility.
Okay. Delegate Kaiser.
You said yes. I'd like to move the bill as amended.
We didn't vote on the amendments yet. So are you moving the previous question, Delegate?
I'd like to, thank you, yes.
Okay, we are, so we're voting on the amendments as presented in the reprint. Those in favor of the amendments in the reprint, please raise your hand and say aye.
Aye.
Aye. Those opposed to the amendments? Delegate Ross, are you opposed, or are you just raising, okay, you're virtual.
No, it's still there. Sorry.
Okay, great, that's okay.
By the way,
All
sorry,
right, the
Madam Chair.
amendments pass
Apologies.
unanimously. Now, can I have a motion on the bill as amended?
Move the bill as amended.
I got a motion. Do I have a second? A second on the bill as amended.
Kaiser.
I'm sorry.
Second A second on the
Second.
bill as amended. Okay, thank
Second,
you.
sorry.
We almost died as a result of no second. Okay, those in favor of the bill as amended, please say aye. Raise your hand.
Aye.
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 Any opposition to the bill as amended? Raise your virtual hand so I can see it. Seeing none, the bill passes unanimously as amended. The last bill today is House Bill 1007. This is the prohibition on disability, life, and long-term care insurance. This is another bill that we have discussed extensively. And there has been some real good faith effort in getting us to a place where we could make almost everyone comfortable. And we do have one additional amendment. Lisa, you want to speak to how this bill was amended, or how we're bringing this bill as a. Lisa, you there?
Yeah, I'm
Yeah.
just trying to find the
Me too. I'm trying to find
latest
my folder.
amendment.
Here it is. Okay. So the amendment that in addition to the amendments that you saw yesterday, which are the language essentially in another state where it has been in practice for a number of years and has been supported by the advocates of 1007 in the past. So we thought this was a good place to start. It doesn't get us all the way to a complete prohibition of using genetic testing, but it certainly informs the patient in a very upfront way. And this bill does include informed assent. We are also adding an amendment from Delegate Wells, which or that Delegate Wells gave to me, saying that no carrier may require genetic testing and that this right is unwaivable. So those are the amendments that I would like the committee to consider. Do I have a motion on the amendments? In order for us to talk about it, I need
So
a motion.
moved.
Move the amendment.
Okay, I've got a
Second.
motion. Do I have a second? Got a motion and a second. Okay, discussion on the amendments. And Patrick, going with you.
Again, thank you, Madam Chair. I will defer to our client, ALS Association. I think that we're getting close with these amendments, but I don't think we're quite there yet. And so I want to give her the opportunity to discuss it.
All right, then I will go to Lindsay before I go to Jamie and Vince. Lindsay Jack?
Great. Thank you, Madam Chair. We really appreciate this opportunity to work together on this bill. We do still have some concerns. We just want to be crystal clear on what the intent is. And, our goal here is to ensure patients are not discriminated against with genetic tests. That's the bottom line. And the way that the additional amendments are provided, we just like some more clarification on that because there can be subjectivity towards that. We'd like the ability to not only insurers not access this genetic information, but utilize it. So that's one piece that we would just like to see some clarification in addition to the mandate of not being able to use genetic testing as a prerequisite or condition for receiving an insurance policy. We'd just like to see that it applies to new and existing genetic tests. So I think that we still have some concerns, but we're certainly getting closer to what our goal is to ensure that patients are able to receive genetic testing without the fear of discrimination or prohibitive costs associated with it.
Okay, I have 7 people with their hands up now. I need comments to be brief and to the point. I just heard Lindsay, and Lindsay, you asked for clarification on things on a bill that you've had experience with for at least 5 years. Did you get that clarification in the Vermont language?
We did not work on the Vermont language in terms of that bill that had passed in Vermont years ago. That is not something that
And
we had worked
has
on.
has it worked in Vermont? Have you had any issues in Vermont?
I cannot share for Vermont. I know Carolyn, who's a genetic counselor and genetic that works directly with families in the state and has colleagues elsewhere, can speak to the efficacy of that.
Okay. And before I go on, I just want to remind folks, number one, of the time. Number two, the way that life insurance programs work is that the person gets the entire sum at the end of the person's beneficiary gets the entire sum at the end of the program, at the end of the life insurance plan. There's no, you only get what you need, as there is in regular insurance. So it's a very different kind of program. And as I alluded to yesterday, we have seen long-term care premiums go up significantly because of the utilization of them. And I am so afraid that the same thing will happen with this, but I'm taking a little privilege here, and I apologize for that. I'm going to go. I have two delegates who have something to say, and then I'm going to go to Jamie Sexton. Delegate Kerr. Oh, delegate, we can't hear you. Not yet. Okay, try now. No. Okay, delegate, I'm going to go to Delegate Taveras, and you try to figure out your sound. Delegate Taveras.
Yes, can we just include, it sounds to me that at the crux of the issue, can we just include existing and future members?
Existing and future members, or existing and
Yes.
future tests is what I heard
Yeah,
her say.
test.
I, would accept that as a friendly amendment. But I need now to go to Jamie Sexton.
Thank you, Madam Chair. I really appreciate it. I will be brief here. I just wanted to flag that in the amendment, it has a provision that says the carriers cannot mandate genetic testing for long-term care insurance. But I want to flag that insurance article section 18.120 actually permits carriers that are offering long-term care insurance to limit or deny insurance based on genetic testing. If that provision could exclude long-term care insurance, that would be all that would be necessary to avoid that conflict. So a relatively technical piece of input here, and I apologize for throwing a kink in things.
Yeah, thanks, Jamie. No, no, that's fine. Thank you for bringing that. I am comfortable with removing long-term care from that. So far I'm hearing two technical, I would call them technical amendments to the amendments. One is to include, can't require new or existing or new genetic tests, and the other is to strike out long-term care under that provision. Vince, I'm going to go to you. Vince Ryan.
Thank you, Madam Chair, members of the subcommittee. I'll largely reiterate my comments from the other day. Look, I think on behalf of the American Council of Life Insurers and our members, again, we would prefer not to see legislation move forward, but we realize that there is a spirit of compromise and collaboration in this process. And we feel, Madam Chair, that the amendments that you have offered to the bill strike a reasonable balance between consumer protection and notification and transparency, as well as the need for life insurers' ability to access information that can speak to risk. And so we are comfortable with the bill as reprinted and before you this morning. I can't speak specifically to some of the suggested technical amendments just now without seeing additional language. However, in response to some of the comments that Ms. Jacks made, we would have concerns, and it does, if I understood her correctly, it does that the proponents of this legislation still would like to see an outright ban on long-term care and disability insurers' ability to access, use, and consider genetic test results contained in an individual's medical record. We have concerns with some of the rest of their suggested language that was not included in the reprinted version this morning, which they appear to be advocating for again today. That language would create information dissymmetry. It would not allow for information symmetry. It would blind life, long-term care, and disability insurers access to, again, information that could speak to an individual's risk. Just to remind the subcommittee, we only have one bite at the apple from the very beginning, unlike life insurance, to get the risk analysis right. And so their language would, if an individual would refuse consent with respect to their genetic test result contained in an applicant's medical record, their proposed language would prohibit us from considering that refusal to provide consent as it relates to any decision we would make on the potential policy. And that would treat genetic information, genetic test results differently from any other medical information.
Right, Vince, that amendment is not in this reprint. So
Correct.
Right. So actually, I really do have to stop now because we are delaying other subcommittees, and we've had extensive conversation on this. So I'm going to put it to the committee. Do I have a motion on the amendments in the reprint with removing long-term care insurance and including the words existing and new genetic tests against the prohibition for requiring the test?
So moved.
Second.
I've got a motion and a second. All those in favor of the amendments, please raise your hand, say aye.
Aye.
Is there any opposition to the amendments? Seeing none, amendments are unanimous. Can I get a motion on the bill as amended?
Move as amended.
Second.
Okay, I've got a motion and a second. No more discussion. Sorry, I'm going to cut it off because we kind of understand where everybody's standing right now. On the bill as amended, those in favor say aye, raise your hands.
Aye.
Is there any opposition to the bill as amended?
I'm gonna abstain. I need to finish doing my homework. I didn't get all my questions answered.
Okay. Anybody else abstaining or opposing? Seeing none, the bill passes. I'm sorry that, we couldn't get all the way there, but this is a very complicated issue, and I think we have actually moved the bill forward on this, or the concept forward on it. So thank you all for your cooperation and collaboration on this. This meeting is adjourned, and those who need to go to government ops, the chair is waiting for you. Thank you very much.